And now we're on to lupus. Lupus, the great imitator. Also, as a point of interest, it means wolf in Latin. There are a phenomenal number of ways that lupus presents, and it has the capacity to be a very different disease for many different types of people. That said, there are some consistencies, and this is what you'll be expected to keep in mind. The absence of these consistencies will likely help you keep lupus either on or off your differential. First off, some epidemiology, which is often very important for this disease. 90% of patients are female and between the ages of 14 and 45. Most of these women are black, a population that also tends to have more severe cases. Though I won't say it's impossible, with a gender skew like this, I'll say that it's very, very unlikely you'll see a male with this disease in a Step 1 question, so have it in your mind whenever you see a young woman with something that smells autoimmune in nature. The symptoms are very varied, and unfortunately there are a lot of nonspecific symptoms. The nonspecific ones include fever, fatigue, and weight loss. There are also certain conditions that people with lupus are predisposed to having, including Libman-Sachs endocarditis, hilar adenopathy, and Raynaud's phenomenon, all of which can help you sort through your differential, but are not technically diagnostic. In fact, the ones that you really need to know are captured in the mnemonic I'm damn sharp. This includes the immunoglobulins, which we'll discuss in some detail in a moment, as well as a wide variety of symptoms, including the classic malar or butterfly rash over the face and cheeks, the discoid rash, ANA, mucositis, neurologic disease, serositis, which can include pleuritis and pericarditis, hematologic disorders, arthritis, renal disorders, and photosensitivity. It can most definitely include a wide variety of organ groups, but you should pay particular attention to the skin, kidneys, which by the way are the most common cause of death in people with this disease, blood, brain, and joints. The heart and lungs tend not to be affected directly, with notable exceptions including Libman-Sachs endocarditis, as we mentioned earlier, usually being a benign finding, as well as pericarditis, which is often, again, not a serious morbidity of the disease. Pulmonary complications include pleuritis, which results in a pleuritic chest pain, but this is often not seen with an acute presentation. Within the other organs, there may be more serious sequelae. For example, in the kidneys, patients can have immune complex deposition. Which type of hypersensitivity reaction would this be? Exactly, 3. This type of renal disease can be very serious, often with a nephritic picture, and eventually leads to renal failure, a common cause of death in patients with lupus. Another unfortunate and common cause of death in patients with lupus is infection, which patients can be predisposed to for a wide variety of reasons, from their underlying disease to the controller medications and their immunosuppressive side effects. In making the diagnosis of lupus, there are a number of serologies that are classically ordered to help confirm the diagnosis. The 4 that we'll discuss here are anti-nuclear antibodies, antibodies to dsDNA, anti-Smith antibodies, and antihistone antibodies. ANA is probably the best known of all of these, and while it has a good sensitivity to help ensure all the cases are picked up in screening, it is not very specific for lupus, and further testing and clinical evidence is often needed. The second antibody, anti-dsDNA, is a much more specific indicator, and usually indicates severe disease. Similarly, anti-Smith antibodies are very specific for the disease. If you are questioning if a patient has lupus and don't think you can go off clinical evidence alone, ANA positivity usually is good to help guide your diagnosis, but dsDNA and Smith antibodies really confirm your suspicion. The final antibody discussed here is antihistone antibody, which are actually not related to SLE. They are related to a disease known as drug-induced lupus, and may have similar clinical features, but drug exposure is a crucial piece of confirmatory evidence. The 3 drugs that are classically linked with drug-induced lupus are hydralazine, used for severe hypertension, procainamide, an antiarrhythmic, and isoniazid, an anti-TB drug. These can be remembered with the acronym HIP, as in it's not hip to have lupus. But again, as it is the great imitator, it's important to recognize that antibodies from lupus can cross-react with other antibodies used in different diagnostic tests and cause false positives in those other tests. The classic example of this is syphilis testing with RPR and VDRL. The treatment of lupus is very complicated. We'll discuss some of the important drugs in the pharm section of this chapter. Sarcoidosis is a disease that is marked by a widespread formation of what are classically described as non-caseating granulomas. Whereas the granulomas in diseases like TB are known for their caseous necrotic center, these granulomas appear cleaner without the same necrotic interior. On histology, there are 2 other important findings, Schoeman and asteroid bodies, which are worth remembering. As in lupus, this disease is also very common in black females. There are an incredible number of presenting complaints for patients with sarcoidosis, and as such, it would be worthwhile to try to get a sense of what all of them are. Nevertheless, in terms of answering Step 1 questions, if you see a vignette that describes a young African-American female with a respiratory problem, sarcoidosis should shoot pretty high up on your internal differential. More importantly, there's a restrictive lung disease associated with sarcoidosis, as I just mentioned, and chest X-ray will classically show bilateral hilar lymphadenopathy. Aside from this, other signs include Bell's palsy, erythema nodosum, and uveitis. Lab findings usually reveal two classic findings. The first is an elevated level of ACE, or angiotensin-converting enzyme. The second is an elevated serum calcium level, which occurs because the macrophages in the granulomas activate more vitamin D, leading to increased gut absorption of calcium and thus hypercalcemia. The management for sarcoidosis is admittedly very complicated, but what you should know is that patients who do appear to require acute treatment often benefit from steroids. You will not be responsible for understanding the intricacies of management. The next disease we'll discuss is polymyalgia rheumatica, a disease marked by pain and stiffness in the proximal muscles, including the shoulders and the hips. There are often constitutional symptoms, including fever, malaise, and weight loss. The classic description is that there is muscle pain, i.e. myalgia, but there is no muscle weakness. This is most commonly a disease of older patients, often greater than 50 years old. The most important piece of this disease to recognize for your board exams is that it is often associated with temporal or giant cell arteritis. That means that patients may either present with both or have a history of one with a second presentation with the other. Either way, keep the two linked in your head in case they do present together. There is no single lab finding that will help you confirm the diagnosis of PMR, but an elevated erythrocyte sedimentation rate in an otherwise healthy patient may be a nonspecific sign of inflammation caused by this disease, and as a side note, also of temporal arteritis by itself. Creatine kinase values are normal as there is no breakdown of the muscle itself, as will happen in diseases like polymyositis or dermatomyositis, which we will discuss in the next fact. The treatment, as with most autoimmune diseases, is steroids, namely prednisone, which can change patients' clinical appearance from phenomenal pain to virtually asymptomatic within a couple days. Fibromyalgia is something of an interesting disease. The typical clinical vignette consists of a middle-aged woman who complains of diffuse pain all over her body, concentrated around a large number of points with no apparent physical cause. This is normally associated with several other symptoms, including stiffness, paresthesias, poor sleep, and fatigue. It's thought potentially to have a neuropsychiatric etiology. Because there is no as yet agreed upon cause, treatments vary considerably and will likely not be tested on step 1. The next two diseases are tough to keep straight, likely because they're fairly obscure and sound similar. Also, they're always mentioned and taught in tandem. These two diseases are, of course, polymyositis and dermatomyositis. Polymyositis is a disease marked by progressive symmetrical proximal muscle weakness, not pain. Classically, like polymyalgia rheumatica, it includes proximal muscle groups. The way to truly get at this diagnosis in part will require a muscle biopsy. The pathophysiology is that there is a CD8 T cell-induced injury to the muscle cells, revealing evidence of perifascicular inflammation, which means around the fascicles, but not in them. Look for a younger person with shoulder weakness in vignettes. In dermatomyositis, the findings are similar, but the operative change is in the word, dermato, or the skin findings. Gutron's papules on the hands are the classic finding, and there may also be wearing of the hands that is described as mechanic's hands. You may also observe a malar or heliotrope rash on the face. You can see this in the picture. It's important to know that these patients may develop amyopathic dermatomyositis, meaning all the skin findings of dermatomyositis, but no damage to the muscles. The muscle damage may start late in the course of the disease or may never occur. As we've discussed, you can make these diagnoses with biopsy, but usually the best confirmatory evidence is actually done by lab testing, often with increased CK and aldolase, as well as positive anti-Jo1 antibody. ANA can also be positive in these patients, as this is one of the many diseases, aside from lupus, that have a positive ANA. The treatment? You guessed it, steroids. There are a wide variety of neuromuscular junction disorders, but there are probably only two that would show up on your boards, and these are myasthenia gravis and Lambert-Eaton, sometimes known as Lambert-Eaton myasthenic syndrome. Of the two, the most common is myasthenia gravis. If you recall the normal physiology of the neuromuscular junction, first, an action potential passes down a presynaptic neuron. As it approaches the end, it opens a voltage-gated calcium channel, which allows the neurotransmitter vesicles to be released from the presynaptic neuron. The neurotransmitter in the neuromuscular junction is acetylcholine, and as acetylcholine makes it to the motor end plate on the postsynaptic muscle cell, it binds to acetylcholine receptors and triggers an action potential to propagate along the muscle fibers, leading to muscle contraction. In myasthenia gravis, patients have antibodies against the postsynaptic acetylcholine receptor, which causes them to reduce in number. This means that no matter how much stimulation comes from the nerve, it becomes very difficult to cause muscle contraction. These patients then end up presenting with difficulty contracting muscles that work very frequently, classically the eyelids and extraocular muscles. This often leads to ptosis and diplopia. Generally, they may feel weak as well. If patients continue to work out the muscle, they have more and more difficulty using that muscle. If you think about it, this makes sense because the acetylcholine receptor is not responding to signals from the presynaptic neuron, and no matter how hard you try, you can't get the levels of acetylcholine to increase enough to cause steady contractions. In terms of clinical vignettes, look for a patient, normally female, who complains of feeling weak and having trouble seeing, which gets progressively worse throughout the day. Normally, the acetylcholine that's released into the synaptic cleft is broken down by acetylcholine esterase quickly. However, if you inhibit this enzyme, you can effectively increase levels of acetylcholine in the cleft and inadvertently drive more muscle contraction. This is exactly how you confirm the diagnosis of myasthenia gravis, by giving an acetylcholine esterase inhibitor called edrophonium and seeing if symptoms improve. One important board-relevant fact is that both of these syndromes have a paraneoplastic relationship with particular tumors. Myasthenia gravis tends to occur in patients with underlying thymomas. In contrast, patients with small cell lung cancer are more likely to develop Lambert-Eaton syndrome. This latter syndrome is quite different from myasthenia gravis. Here the problem starts earlier than the acetylcholine receptor. Antibodies are formed against the presynaptic neuronal voltage-gated calcium channels. Therefore, when patients send a signal to contract, the action potential travels along the neuron, gets to these voltage-gated calcium channels, and causes them to open. But since they are getting impaired by these antibodies, only a small amount of calcium is allowed to enter the presynaptic neuron to allow for neurotransmitter release. Since not enough calcium enters, not enough neurotransmitter is released, and a weak contraction is elicited. However, unlike myasthenia gravis, if more and more attempts are made, more signals are sent, more calcium is allowed into this presynaptic neuron, and more neurotransmitter is released, leading to stronger contractions. The exact opposite of what happens in myasthenia gravis. Also, when you give these patients drugs like edrophonium, you don't expect much of a change at all, since this is not the problem underlying the disease. As previously mentioned, it's often seen with small cell lung cancer. As you'll see from the name of this fact, the name scleroderma is not as commonly used anymore, and actually has in part been replaced by the term progressive systemic sclerosis. You should think about this disease as a widespread, diffuse, uncontrolled deposition of collagen, leading to fibrosis in the body that, like most autoimmune diseases, affects mostly females. As per the name scleroderma, this often happens in the skin, appearing with puffy and taut skin without wrinkles. However, many other organ systems are affected, including the renal, pulmonary, cardiovascular, and GI systems, which is the primary cause of mortality. There are two major types you should know for step 1. The first is called diffuse scleroderma, and this is exactly what it sounds like, a widespread disease affecting skin and many visceral organs. It's rapidly progressive. The antibody that is most often telling of this disease is anti-SCL70. It's also known as anti-DNA topoisomerase I antibody. The second type is a form of limited scleroderma which affects certain areas more specifically. This is called Crest syndrome and stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Usually these patients have fewer skin findings than people with diffuse disease, and if they do, you tend to see it on the fingers and the face. The antibody here is also different, usually the anti-centromere antibody. Remember, this presentation won't necessarily sound like scleroderma immediately, because there won't really be that many skin findings. Instead, there may be non-specific skin findings on the fingers, some vague history of gastroesophageal reflux disease, cold intolerance, manifested by Raynaud's syndrome, and x-rays of the hands indicating calcium deposits under the skin.